All right, in this explainer, we're going to dive deep into chemotherapy-induced nausea and vomiting, or as you'll see it, CINV. And this is specifically for all of you pharmacists gearing up for the PBC MCQ exams, so you've definitely come to the right place. We're going to break down all the clinical guidelines to give you a really clear, practical grasp of this critical topic. Okay, so here's the plan. We're going to start with the absolute basics. What are the different types of CINV and what triggers them? Then, we'll walk through how to assess a patient and set our goals. From there, we'll get into the really important stuff, risk stratification and all the prophylactic strategies, both non-drug and drug-based. And finally, we'll cover what to do when things go wrong with breakthrough CINV, and I'll leave you with some key therapeutic tips. It's all designed to build a complete picture for you. All right, first things first, let's get down to the fundamentals. You really have to understand the different types of CINV and their triggers, because honestly, this foundation dictates every single treatment decision we make down the line. So, CINV isn't this one single, simple thing. It's actually a spectrum of 5 very distinct conditions. And whether a patient gets, say, acute symptoms versus delayed ones, well, that depends almost entirely on the specific chemo drugs being used, the dose, and even how fast it's infused. So let's break down those 5 types. Okay, this table right here is super important. What you really need to key in on for your exam are those first 2 types. Acute CINV, that hits fast, within 24 hours, and it's mainly driven by a flood of serotonin in the gut. But delayed CINV, that shows up after 24 hours and is mediated more by a different player, substance P. This difference in neurotransmitters is exactly why our drug choices change. The other 3, anticipatory, refractory, and breakthrough, are all about how well we manage things in the first place. But it's not just about the chemo drugs themselves, right? We also have to think about the patient. These are all independent risk factors that can make someone more likely to experience CINV. Things like being younger, female, a history of motion sickness. And this one's a little counterintuitive, but having a low history of alcohol intake actually increases the risk. And of course, the single biggest predictor of CINV is having had poor control in a previous cycle. So now that we have a handle on the what and who's at risk, let's talk about our game plan. What are our goals, and how do we properly assess the patient? This is all about setting the stage for success. And this is absolutely crucial. Our number 1 goal here is prevention. We want to stop the nausea and vomiting before it even has a chance to start. And this isn't just about patient comfort. Uncontrolled CINV can lead to really serious complications. We're talking dehydration, malnutrition. It's a huge reason why patients might need to delay or sometimes even refuse to continue their life-saving chemo. So our job is to maintain their quality of life and make sure they can stick with their treatment. You have to be systematic about your assessment. It's non-negotiable. Because before we jump to treating CINV, we have to be absolutely sure that's what we're looking at. I mean, a patient with cancer could be nauseous for a dozen other reasons. Maybe a bowel obstruction, maybe brain mets, or maybe it's another one of their medications, like opioids. That's why we dig deep with a thorough history, do a physical exam, and check their labs to rule other things out, and see if they're dehydrated. Okay, now we're getting to the absolute heart of prevention. This is where we figure out just how high the risk of CINV is based on the specific chemotherapy regimen the patient is getting. This one step is going to dictate our entire prophylactic game plan. So pretty much every single anti-cancer drug gets sorted into one of these 4 buckets. And think about it like this. If you give a high emogenic chemo, or HEC, without any anti-nausea meds, over 90% of your patients will vomit. That risk then drops with each level, all the way down to less than 10% for the minimal risk drugs. This classification is our guide for everything that comes next. So take a look at this table. It's got some of the big players for injectable drugs. For your exam, you absolutely have to know that cisplatin is the classic textbook example of a high-risk agent. And notice how cyclophosphamide can be either high or moderate risk. That just depends on the dose. It's a great reminder that it's not always just the drug, but how much of it we're using. And here it is. This is a huge clinical pearl, and trust me, it's a favorite for exam questions. Carboplatin. So while it's officially classified as moderately emetogenic, in the real world, we treat it as if it's highly emetogenic. You have to remember this exception. We always manage carboplatin with the full HEC level prevention strategy. Now, the same rules apply when we're talking about oral chemo drugs, though as you can see, not as many of them fall into that high-risk category. The main one to burn into your memory here is procarbazine. That's the standout high-risk oral agent. A lot of the more common targeted therapies and TKIs tend to fall in that moderate to low risk space. Okay, so we've done our homework, we've assessed the patient, we know the risk level of their chemo. Now it's time to build our prevention plan. We'll touch on some important non-drug strategies first, before we get into the real cornerstone of management, the drug algorithms. Now, these non-drug approaches are really valuable tools to have in our toolbox. Simple advice like eating small, light meals and staying away from really strong smells can honestly make a huge difference. And behavioral techniques like relaxation can be a game changer for that anticipatory nausea. These strategies are great because they empower patients and really supplement the medications we're going to use. All right, this is it. This algorithm is pretty much the Bible for managing CINV. It's our playbook. It lays out the whole process, from figuring out the risk on the left to the specific prevention pathways, and then finally, what to do if the patient has breakthrough symptoms on the right. We're going to break this whole thing down, starting with those prevention pathways. When we're dealing with high-risk chemo, we have to be aggressive. We go in with everything we've got right from the start. On day 1, to cover that acute phase, the gold standard is a 4-drug combo: an NK1 receptor antagonist, a 5-HT3 receptor antagonist, olanzapine, and dexamethasone. Then, to cover the delayed phase, which remember is driven by substance P, we keep them on the olanzapine and dexamethasone for days 2, 3, and 4. Okay, stepping down to moderate risk, things get a little simpler. For the acute phase on day 1, the standard is a 2-drug combination, a 5-HT3 antagonist plus dexamethasone. Then for that delayed phase on days 2 through 4, we usually just continue with dexamethasone by itself. And don't forget our big exception. If that MEC agent is carboplatin, you ignore this and use the HHC regimen we just talked about. And as you'd expect, as the risk drops, so does our strategy. For low-risk chemo, a single dose of just one agent on day 1 is usually all you need. That could be a 5-HT3 antagonist, dexamethasone, or a dopamine antagonist like prochlorperazine. That's it, no need for delayed coverage. And for minimal-risk agents, we don't even need routine prophylaxis. So we've been throwing around these drug class names: 5-HT3 antagonists, NK1 antagonists. Let's actually dig into what these are and how they work. This is definitely high-yield stuff, so listen up. The 5-HT3 antagonists are real workhorses in our arsenal, but you've got to know the difference between the generations. First-gen drugs like ondansetron are fantastic for acute CINV. But the second-gen agent, palonosetron, has a way longer half-life, and that gives it activity against both acute and delayed CINV, which is really useful in moderate-risk situations. For both, common side effects are headache and constipation, and you always need to be thinking about the risk of QTc prolongation. Now, the NK1 antagonists. The big takeaway here is that they target substance P. That's what makes them so essential for preventing that tricky delayed CINV in our high-risk patients. But the most important thing you need to remember for your exam is the drug interaction. These guys are CYP3A4 inhibitors, so when you use one with dexamethasone, you must cut the dexamethasone dose, usually by about 50%. This is a classic clinical interaction you have to know. Okay, let's round out our pharmacology with these other key players. Dexamethasone is a powerhouse, especially for delayed CINV, even if we don't fully understand how it works. Then you have the dopamine antagonists like prochlorperazine and metoclopramide. They're great for low-risk prevention or as rescue drugs, but you've always got to be on the lookout for those extrapyramidal side effects. And then there's olanzapine, this super versatile drug that hits multiple receptors and has carved out a huge role in both prophylaxis and for treating breakthrough symptoms. Okay, so what happens when we do everything right, we follow the guidelines perfectly, and our patients still get sick? Despite our best efforts, some patients will experience breakthrough nausea and vomiting. So let's talk about the rescue plan. So let's go back to our big roadmap, but this time we're looking at the right side of the chart, the part labeled Treatment of Breakthrough NV. This is our step-by-step guide for when things don't go according to plan. The game plan here is all about logical escalation, and the key principle is you add an agent from a different pharmacologic class. So if your patient is on a serotonin-based regimen and they break through, you might add a dopamine antagonist like prochlorperazine. If anxiety seems to be a big part of it, adding lorazepam is a great next move. Still no luck? That's when we can escalate to a cannabinoid like nabilone. It's a structured approach, adding different mechanisms of action until we get control. So let's talk a bit more about those adjunctive agents, because they have very specific roles.
Benzodiazepines like lorazepam are perfect for anticipatory nausea. Why? Because that type of nausea is a learned anxiety-driven response, and the anti-anxiety and amnesic effects of lorazepam are perfect for that. Cannabinoids like nebolone, on the other hand, are really reserved for those tough, refractory cases after other options have failed, mainly because of their side effect profile.
All right, let's wrap this all up by putting it into practice. I want to leave you with some key therapeutic tips. These are the pearls that will help you take all this information and apply it effectively. And this right here really hammers home the most important philosophy of CINV management. You have to be proactive. Prevention works way better than treatment, which is why we schedule antiemetics. We don't give them PRN or as needed. And while we prefer oral meds, you have to be ready to switch to IV or rectal if the patient is actively vomiting. For multi-day chemo, you cover every single day. And for the high-risk stuff, you keep that coverage going for a couple of days after to catch that delayed CINV.
Okay, I'm gonna leave you with a final clinical challenge, a thought experiment, if you will. This comes up all the time in practice. Your patient is on a big 4-drug HEC regimen, and they did great in cycle 1. No nausea, no vomiting. So for cycle 2, should you back off a little, maybe simplify their therapy? The answer is a hard no. Successful prevention in one cycle is not a reason to de-escalate. In fact, keeping that strong regimen is the best way to prevent anticipatory nausea from ever developing. When it comes to CINV prevention, consistency is everything.